Hello, everyone. Good evening. Welcome to the Journal Club webinar. We will start in 2 minutes, allowing more participants to join. Okay, we start now. Bismillah ar-Rahman ar-Rahim. Dear respected ladies and gentlemen, Assalamu alaikum and good day for all of you from around the world. Thank you for joining us tonight in the webinar number 5 of IVPN Journal Club season number 3. Our mission in IVPN Journal Club is to share the latest published evidence, learn from high caliber and world-class pharmacotherapy experts in analyzing primary literature, read beyond the trial's context, ultimately to optimize clinical practice. Tonight, we are a gathering of over 200 delegates from different countries around the world who came to attend this live session with Dr. Lina Al-Harbi and moderated by Dr. Tamadur Abu Riash. Where we will be discussing the landmark trial, which is the CLEAR trial. This is an eagerly anticipated trial that was published just a few months ago that showed in treating high-risk patients who are unable to tolerate statin therapy with bempedoic acid, it lowers actually the risk of major adverse cardiovascular events. And we will learn that, the new cardiovascular outcomes of this bempedoic acid. Bempedoic acid is definitely already FDA approved, and we will see how this trial will impact our practice and how it will change the guidance. And now I will start by introducing our moderator for tonight, the amazing Dr. Tamadur Abu Riash. Dr. Tamadur is currently serving as the pharmacy virtual counseling clinic team leader as a pharmacist in King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. Dr. Tamadur is a licensed pharmacist with Bachelor of Pharmacy degree, Master degree of Advanced Clinical Pharmacy Practice with combination, and certified professional healthcare quality, and over 10 years of experience in the healthcare setting. Dr. Tamadur is the relation and innovation leader in IVPN patient support listserv, and she is the preceptor in ASHP pharmacies, and also she's a member in the hospital competition at iHope conference. She was 2021, and in February 2021, since then, she's also a reviewer in the Annals of Saudi Medicine. And she is a member of the Pharmacy Scientific and Research Committee at King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. Without further ado, it gives me a great honor and pleasure to introduce Dr. Tamadur to the stage. We are very happy to have you with us. It's always, inspiring to work with you, such a dedicated and passionate leader. Dr. Tamadur, the floor is all yours. Thank you so much.
Thank you, Dr. Ahmed, for this very nice introduction. I'm so humbled about it. Thank you very much for giving me this opportunity today to be with you in this webinar and this journal club. I'm really thankful for the whole IVPN organization for letting me be part of this amazing family. And special thanks, of course, to Dr. Osama, our supporter, our mentor. Today, we will be hosting this journal club, like Dr. Ahmed said, and our speaker will be Dr. Lina Al-Harbi. So Dr. Lina Al-Harbi, she's graduated with Doctor of Pharmacy degree in 2021 from Taiba University, Al-Madinah Al-Munawwara at Saudi Arabia. She completed her 10 months internship in 7 different patient-focused institutions. She's the PharmD class leader for the academic years during 2019 until 2021. She volunteered with the Saudi Red Crescent Authority and several community events with Pharmacy Club at Taiba University. She has 1 year of experience as an ambulatory care pharmacist at Al-Nahdi Care Clinics. In addition that she is currently working as a full-time hospital pharmacist at Prince Mohammed bin Abdulaziz Hospital in the National Guard Health Affairs, covering different areas of pharmaceutical care. So please, everyone, join me to welcome Dr. Lina Al-Harbi. And Dr. Lina, the floor is yours.
Thank you, Dr. Tamadur, for the warm welcoming. So just let me share my screen. Just 1 minute.
Dr. Lina, we still can't see your slide.
Just 1 minute. I'm trying to share my
Okay, sure.
Is my screen now? Is it clear now?
Yes, please.
Yes, we can see it.
Okay, so hello everyone. First of all, I would like to thank IVPN for inviting me here today. Actually, I'm honored to be presented with IVPN Journal Club for the 2nd time. and it's my pleasure to have the opportunity to address such a distinguished audience. Today's Journal Club is on one of the most recent trials that was published in early 2023 in field of cardiology. During the next 30 minutes, we will dig deep into a clear outcome trial that looked into new emerging therapy, bempedoic acid, and on its effect on cardiovascular outcome in a statin intolerant patient. This presentation is structured as follows. We will start off with the background information. Then we will be looking at previous trial. Then I will give you an overview on the study. Finally, I will share my own critique and how it will impact the current practice. Starting off with the key concept for better understanding. So currently, atherosclerotic cardiovascular related conditions remain the leading cause of morbidity and mortality globally. The foundation of a preventive cardiology begins with the assessing baseline atherosclerotic cardiovascular risk. Statin remains the cornerstone therapy for reducing cardiovascular mortality, and that's achieved by multiple mechanisms, including plaque stabilization, reduction in inflammation, and regression of atherosclerosis. Despite these benefits, the use of a statin and optimizing treatment dosing can be undermined in practice due to true or perceived intolerance. So bempedoic acid considered first in class ATP citrate lyase inhibitor. Just as a statin, bempedoic acid lowers the lower density lipoprotein by working on the well-known cholesterol biosynthesis pathway within the hepatocyte and inhibiting ATP lyase citrate lyase. This enzyme is two-step upstream the HMG-CoA reductase, which is the primary target for statin. ATP citrate lyase inhibition will eventually result in LDL receptor upregulation and increased clearance of LDL cholesterol from the blood. It's worth mentioning that bempedoic acid is a prodrug that converted into the active form only in the liver, not in the skeletal muscle, and this explaining the absence of skeletal muscle symptoms. This graph shows the current practice for management of patients with atherosclerotic cardiovascular risk. These patients considered as very high risk if they have a history of a major atherosclerotic event, such as acute coronary syndrome, myocardial infarction, ischemic stroke, and symptomatic peripheral artery disease. Or if they have only a history of one major event and they have high-risk condition, for example, diabetes or chronic kidney disease. First, if the patient met the criteria for very high risk, they will be treated with high-intensity statin despite the age. Ezetimibe will be added if LDL cholesterol is more or equal to 70 milligram per deciliter. BCSK9 inhibitor will be added only if the LDL is still not within the target or non-HDL 100 milligram or more. If the patient not considered very high risk and they are older than 75 years, statin can be reduced to moderate intensity. And they only require double therapy if LDL cholesterol is more or equal to 70. For primary prevention, atherosclerotic cardiovascular risk score should be calculated using pooled cohort equation, or BCE for short, to estimate the 10-year atherosclerotic cardiovascular risk. If patients scored less than 5%, then the management will be counseling on lifestyle modification. Moderate intensity statin may consider in borderline risk and intermediate risk. Ezetimibe may be added to statin therapy if patient is intolerant to the intolerant. And finally, for high risk, they will receive high intensity statin as a primary prevention. Moving to the statin intolerance is defined as one or more adverse effect associated with the statin therapy, which resolves or improves with the dose reduction or discontinuation. The most common complaint are muscle symptoms such as soreness, aches, weakness, cramps, typically affecting symmetrical, large, and proximal muscles. Not all the patient may experience creatinine kinase elevation. Very rarely, myopathy or rhabdomyolysis may occur. Statin intolerance has been reported in 5 to 30% of the patient, with the lowest being in the clinical trials and the highest being in the observational study. Approximately 60% of the patient report muscle symptom as their primary reason for distinguishing the medication. Statin intolerance can be classified as inability, either as a complete intolerance or as a partial intolerance. Complete intolerance, defined as inability to tolerate any doses or regimen of statin, where partial is patient can tolerate the lower dose of statin than required. In this part of our presentation, I will discuss 6 previous randomized clinical trials. Starting off with these large trials that evaluated PCSK9 inhibitors. The Fourier trial enrolled patients with atherosclerotic cardiovascular risk and LDL cholesterol of 70 milligram or more, randomized to receive either evolocumab or placebo, whereas ODC trial enrolled patients with recent acute coronary syndrome and LDL of 70 milligram or more, despite maximally tolerated statin doses, to receive either evolocumab or placebo. After median follow-up about 2 years, those medications were associated with a significant reduction in the risk of ischemic cardiovascular events. The reduction in LDL with evolocumab was 59%, where it was 55% with evolocumab. Bempedoic acid was evaluated in 4 CLEAR trials before the CLEAR outcome trial. The first phase 3 randomized clinical trial was CLEAR Tranquility. Patients were randomized to bempedoic acid, a dose of 180 milligram daily, added to ezetimibe. Result of this trial showed that bempedoic acid lowered LDL by 28.5 in patients with hypercholesteremia at higher risk of cardiovascular and unable to tolerate optimal statin therapy. The second trial was a CLEAR Serenity trial, showed that bempedoic acid reduced LDL by 21.4% in patients with statin intolerance, regardless of the baseline LDL or additional level-lowering therapy. CLEAR Harmony trial assessed the safety and efficacy of this drug in patients with atherosclerotic cardiovascular risk or patient with heterozygous familial hypercholesteremia while receiving maximally tolerated statin. At week 12, bempedoic acid statistically reduced the mean LDL in the blood by 18% versus a placebo, regardless of the intensity of background statin therapy. The primary endpoint in CLEAR Harmony trial was the safety endpoint, which included the incidence of overall adverse events and change in safety laboratory variable. And the percentage in the change in LDL level was only main secondary endpoint. And that's why CLEAR Wisdom was conducted. This was a smaller randomized clinical trial with similar design to the Harmony trial, but the primary efficacy endpoint being the percentage change in LDL level at week 12, and it did report similar results. Now let me give you an overview on the CLEAR Outcome trial. So CLEAR Outcome trial is a double-blinded, randomized, placebo-controlled trial published in March 2023 in the New England Journal of Medicine that took place in 1,250 sites around the world. And it was designed to determine the effect of bempedoic acid on adverse cardiovascular event in a mixed population of patients for whom primary and or secondary prevention is clinically indicated, but who were unable or unwilling to take guideline recommended doses of statin. This slide illustrates the study design and allocation. A total of 14,016 eligible patients enter a 4-week run-in period, during which they received single-blinded placebo. If a patient complains of unacceptable adverse effects, or if adherence was less than 80% according to the tablet count, they were deemed to be ineligible for randomization. 13,970 patients who successfully completed the run-in period were randomly assigned to 1:1 ratio to receive bempedoic acid at a daily oral dose of 180 milligram or matching placebo. At 6 months after randomization, if the LDL cholesterol exceeded the threshold, the investigator could adjust the lipid lowering regimen according to the standard of care and local guideline. So the trial included patients 18 to 85 years of age if they met one of two criteria. Either a previous cardiovascular event and those considered the secondary prevention patient, or a clinical feature that placed them at higher risk for a cardiovascular event and those considered the primary prevention patient. All the patient must provide written informed consent. Also, eligible patients should have report being unable or unwilling to receive a statin due to adverse effect or that had started or increased during statin therapy, and patients who are receiving very low average doses of statin without an acceptable side effect could be enrolled. Patients with renal or hepatic dysfunction were excluded. Also, patients who lack of adherence or intolerance were also excluded during the run-in period. The primary endpoint was a 4-component composite of major adverse cardiovascular event defined as death from cardiovascular causes, non-fatal myocardial infarction, non-fatal stroke, or coronary revascularization. Key secondary endpoint included a 3-component composite of death, cardiovascular causes, non-fatal stroke, or non-fatal myocardial infarction. Also, secondary endpoint included fatal or non-fatal myocardial infarction, coronary revascularization, death from either a cardiovascular cause or death from any cause. This was an event-driven trial, was designed to provide at least 90% power to detect 15% reduction in the relative risk of the primary endpoint event. The median duration of follow-up was about 40 months, and all efficacy endpoint was analyzed using attention to trait analysis. The baseline characteristic of the patient in this trial were similar. The mean age was 65 years and around 40–80% were female. The mean LDL cholesterol was 139 milligram per deciliter. Almost 70% patients required secondary prevention, and 22% taking a statin, and 11% of the patients were receiving ezetimibe. The result of the primary endpoint event was significantly lower by 13% with the bempedoic acid than with the placebo. The first 3 key secondary endpoint was significantly lower with the bempedoic acid, and the result of other secondary endpoints, which are fatal or non-fatal stroke, death from cardiovascular causes, and death from any cause, did not differ significantly between the two groups. The observed differences in mean LDL cholesterol after 6 months of treatment with a bempedoic acid was a 21.1 reduction in favor of bempedoic acid, and the difference in the percentage change in the median high sensitivity C-reactive protein was a 21.6, also favoring the bempedoic acid. The overall incidence of adverse events did not differ meaningfully between the bempedoic acid and the placebo group. Elevation of hepatic enzyme level and the renal event were statistically different, and the incidence of hyperuricemia was higher in the bempedoic acid group than in the placebo group, as well as the incidence of gout and cholestasis. So the author concluded that among patients with statin intolerant, treatment with bempedoic acid was associated with lower risk of major adverse cardiovascular events. Now we have come to the main part of this presentation. As mentioned before, the trial was published in New England Journal of Medicine, which considered as a peer-reviewed journal with impact factor of 176, which was just updated in 2023, making it the top-ranking medical journal. The trial was funded and designed by the sponsor in the collaboration with the Cleveland Clinic. And the first author, Dr. Stephen, is a cardiologist working currently at the Cleveland Clinic. Okay, so when it comes to the inclusion criteria, in my perspective, inclusion of both secondary and primary prevention patients will provide more data on those two different population groups. Another point to consider is to classify a patient as a statin intolerant, a minimum of 2 statins should have been admitted, including at least one at the lowest approved dose. Also, in this trial, patients who were receiving very low doses of statin without an acceptable adverse effect were included, making this definition of statin intolerance inadequate. Patients were excluded if they lack adherence, which on one hand will measure the efficacy here. On one hand will measure the efficacy accurately, but in the other hand, it does not reflect the real life practice. As mentioned earlier, this trial was analyzed using attention to treat analysis. That means that all randomized patients should be analyzed. Of note, patients who lack adherence were excluded after randomization. Also, patients who reported intolerance were excluded even though they met the inclusion criteria, thus diluting safety profile result. In other words, side effect severity is not accurately assessed during actual study duration. Okay, so the baseline characteristic of the patient and the trial were similar, and around 50% were female. This is a larger percentage of female than that in the other trials. LDL at baseline was 139 milligram per deciliter, which considered higher than the baseline LDL baseline in Fourier and Odyssey trial. It was 92 milligram per deciliter. Also, 1/3 of the patients were taking other lipid lowering medication, and that may influence their lipid profile. Finally, there was underrepresentation of other racial group, and we know that there are some racial group at higher risk for atherosclerotic cardiovascular disease. A specific type of randomization was not mentioned. The trial was multi-center, which may increase its generalizability. A run-in period may introduce selection bias since participants who actually met the inclusion criteria at first are excluded and not included in the final analysis. Hence, they don't represent the population and compromise its external validity. In addition, they may underestimate the treatment adverse event. Bill count may more accurately measure the medication adherence, and it's the standard for monitoring medication adherence for both clinical trials and clinical practice. The primary endpoint, which was composed of major adverse cardiovascular events, was appropriate for the study objective, which was to determine the effect of bempedoic acid on adverse cardiovascular events. Endpoint was clinically relevant and applicable to the clinical practice. However, the use of composite endpoint may dilute the negative effect and hide the real difference in other endpoint, and averaging the overall effect. We will see in a bit in the results section. Laboratory endpoints, which was the LDL cholesterol and high sensitivity C-reactive protein, have a strong association with atherosclerotic cardiovascular disease. In fact, inflammation assisted by high sensitivity C-reactive protein is a stronger predictor for risk of future cardiovascular events and death than LDL cholesterol. 40 months was the time period used when measuring outcome, which was longer than the other CLEAR trials, but similar to when compared to Fourier and ODC trials. So for statistical analysis, power was set to 90%, which estimated that 12,600 patients would be needed to be enrolled, and 13,970 patients were enrolled. So the power was set and met. Attention to treat analysis was used, which is the preferred type of analysis in a clinical trial because it mimics the real life practice, and it's based on as randomized as analyzed. However, not all randomized patients in this trial were included in the final analysis. Generally, the results were well described, data presented clearly and consistent with the table and graphs. Around 95% of the patients completed the final primary endpoint. The results were statistically significant. However, is it clinically meaningful? To answer this question, number needed to treat should be calculated. It was 63 patients, meaning that we have to treat 63 patients with this drug to prevent one additional bad outcome. So the question for you, do you think this drug is can be like clinically significant when compared to other medications? I pointed out earlier that the use of composite endpoint may dilute the negative effect. As we can see in this table, fatal and non-fatal stroke, death from cardiovascular, and death from any cause did not differ significantly when was measured separately. When it was measured with the composite endpoint, it was statistically significant. However, the reduction in LDL cholesterol was consistent with the other CLEAR outcome, being the highest when added to ezetimibe, as showed in CLEAR Tranquility trial. Finally, I would like to address the following question: how this therapy might be used in real-life practice. This graph shows the proposed management of statin intolerance, and it was adapted from the National Lipid Association statement. So first, for patients with suspected statin intolerance, practitioners should first consider the nocebo effect, which defined as the expectation of harm result in a perceived side effect that may be unrelated to the pharmacological effect of the drug. The practitioner should identify tolerable statin regimen before classifying the patient as a statin intolerant. And that can be done by multiple strategies, by switching statin type, reducing the dose, or adding adjunctive therapy, or even using unconventional dosing regimen, for example, every other day or twice weekly. Non-statin can be considered without statin in patients with complete intolerance, which is uncommon, accounting only for 5% of the patient. However, the question remains which one of the non-statin therapy would be the safest and most effective agent. Although the evidence of a base of non-statin intervention to lower adverse cardiovascular events is not as well as developed for that of a statin, but has been growing in the recent years. In my humble opinion, head-to-head trials and economic study as well is needed to answer this clinical question. And by that, I reached the end of the presentation. Thank you so much for your attention.
Thank you very much, Dr. Lina, for your fruitful lecture. It was really amazing. You covered all the research. MashaAllah, we liked it. Let's now see if our audience have any questions. Hibatullah, she's saying, great. Thank you, Hibatullah. Any question from our audience? MashaAllah, you covered it all. That's why. So thank you again, Dr. Lina. We are happy again to have you with us, and inshallah, we will have you in our next webinars. Thank you, everyone. Thank you, everyone, for our audience who attended this webinar. Before we leave you, I would like to highlight some. I would like first to sincerely encourage everyone and welcome everyone to join our IVPN journal club listserv. If you are not yet part of this vibrant community for endless opportunities of growth, please visit our website, which is www.ivpn-network.com, and register to our listserv, including journal clubs and other listservs like patient support and neuroscience. Please also note that certificates of attendance will be issued to you within 7 days. Also, the recording for this session will be uploaded in the IVPN library within 15 days. And at the end, stay tuned for the upcoming new activities with IVPN Journal Club listserv in August. And hopefully that we can see you all. Again, thank you very much, Dr. Lina Al-Harbi, and thank you, Dr. Ahmed, for the organization of this webinar and for this amazing opportunity to be with you. And have a nice evening, everyone. Take care.
Thank you.